Shall we start, sir? Okay. Okay. Good morning. To this early morning session, I am going to talk about association of methylene tetrahydrofolate reductase gene C677T polymorphism in patients of cataract. As we know, MTHFR is the main regulatory gene for folate and homocysteine metabolism. It is the main methyl donor during homocysteine metabolism, and its deficiency causes homocysteinemia. There are 34 rare and 9 common variants known to us. C677T variant is the most common cause for hyperhomocysteinemia. This occurs due to point mutation, which leads to substitution of cysteine to thymine at 677 position, and later on substitution to alanine to valine at this position. And this makes the gene less thermostable. This is a homocysteine metabolism. We can see the MTHFR. You have the pointer? Pointer. Okay, as you can see, the MTHFR, folic acid, vitamin B12, and vitamin B6 are the main factors. Hyperhomocysteinemia can be due to deficiency of vitamin cofactors or due to functional polymorphism of the gene. Homocysteinemia is associated with endothelial cell injury, and it is also said as a stressor for lens epithelial tissue, which is associated with cataract formation. We can see hyperhomocysteinemia causes oxidative stress, which leads to lens opacification and visual dysfunction. MTHFR polymorphism is also associated with primary open angle glaucoma, arteriovenous occlusion, ARMD, and retinal emboli. Tan et al. In their study said that about 33% of the risk for incident cortical cataract from MTHFR polymorphism is due to indirect pathway, that is due to homocysteine elevation, and while 2/3 is due to the direct pathway of the polymorphism. Similar study was carried out by Wang XB in China, and the study indicated that the variant of MTHFR gene might individually or jointly influence susceptibility to age-related cataract. On the basis of this, we investigated MTHFR gene polymorphism C677T in the patients of age-related cataract in a case control study. It was conducted at Swami Dayanand Hospital in collaboration with Institute of Human Behavior and Allied Sciences, Delhi. 40 cases of cataract and 40 healthy individuals without cataract were enrolled, and they were subjected to estimation of MTHFR gene polymorphism, serum homocysteine levels, vitamin B12, and folic acid. Exclusion criteria: any patient with complicated cataract or traumatic cataract, diabetes mellitus, coronary artery disease, malignancy, or multivitamin supplements were excluded. 10 ml of the sample were taken, and the MTHFR gene polymorphism, serum homocysteine level, and vitamin B12 and folate level was studied. DNA extraction was done using commercial kits available by restriction fragment length polymorphism method. Serum homocysteine assessment was done using Dilab homocysteine enzymatic cycling reagent kit, while serum vitamin B12 and folate assessment was done by commercially available kit using chemiluminescent analyzer. So we found that MTHFR C677T gene polymorphism in cataract cases was significantly higher than that in control cases. This is the PCR showing, we can see the CT showing polymorphism. There are two bands showing, this is the polymorphism gene. In the bar diagram, we can see the polymorphism was seen in 45% of the cataract cases, while only general population has 22.5% polymorphism. So the serum homocysteine level, folic acid, and vitamin B12 level, although it was found to be higher in the patients of without cataract, but it was not significant. We conclude that if future research is carried out in larger sample and broader ethnicity group, then MTHFR gene polymorphism may represent a new biomarker. Since our study showed, just a minute. In our study, the MTHFR gene polymorphism was significantly higher in the patients of cataract. than compared to the patients without cataract. So the present study broadens our understanding about genetic markers of age-related cataract and also emphasizes the need of investigation of association of MTHFR C6717 T gene polymorphism in large cohort of Indian population. Thank you.
Any questions? Okay, ma'am, I just wanted to have a few questions.
Yes, sir.
Firstly, did you find any difference in the type of cataract in these patients who had this polymorphism present?
Sir,
in the sense, in the morphological
sir, we
structure?
did not do any statistical analysis. We took all the age-related cataracts. But we can further, we are planning to do further like cortical cataract, nuclear cataract, we can segregate.
Okay, the second thing is, since it is known that hyperhomocystinuria can also cause vascular problems like CRVO, all those problems,
Okay.
did you study the association of the individuals who had this polymorphism in addition to cataract? Did they have any other lesions?
No, we did not.
You
we did not consider that.
So otherwise, actually, it's a nice study, but the problem is there are so many confounding factors in age-related cataract that it's very difficult to sort of
Yes, sir.
pin it down
In
to...
our study, in fact, we did not find hyperhomocystinemia. So we are taking it as it was mainly due to the direct pathway, which was due to the polymorphism, gene
Okay, but the
polymorphism.
homocysteine levels were normal in these patients.
Yes, it was raised in few patients, but it was not statistically significant. So it was directly leading to the polymorphism was leading to age-related cataract.
So thank you, ma'am. So a good first step, I think it can lead to further studies.
Okay.
What was the age criteria?
Ma'am,
Ma'am, what was the age criteria?
50.
50 plus, yeah. Okay,
All the patients' case and control were 50 years age.
thank you.
Okay.
So our next speaker is Dr. Vishal Kumar. Outcome of cataract surgery in patients of Down syndrome. Dr. Vishal?
can we have the timer, please?
इसमें नहीं आ रहा इसमें नहीं आ रहा
Is it going to take time? Then we can... next कौन है बोल रहे हैं ready रहेंगे.
Request, please, next is Dr. Alisha Kulkarni. Please be ready with your presentation.
Can I start? Okay. Good morning, everyone. I am Dr. Vishal Kumar. I am here to present outcomes of cataract surgery in patients with Down syndrome. So coming to the introduction part, Down syndrome is one of the most common chromosomal anomalies with a reported incidence of 1 in 700 live births. Down syndrome can be identified by its characteristic facial features and mental retardation. It is also associated with several ophthalmological manifestations, including different patterns of strabismus, cataract, nystagmus, keratoconus, eyelid abnormalities, amblyopia, and retinal abnormalities. Cataracts in Down syndrome patients results in significant visual impairment, and it can lead to amblyopia if not treated early. So the increased prevalence of cataracts in Down syndrome is attributed to the increased levels of superoxide dismutase, which leads to elevated levels of reactive oxygen species. Cataract surgery in Down syndrome patients is challenging. The challenge includes preoperative evaluation, intraoperative surgical difficulties, and postoperative visual rehabilitation in these patients. Postoperative visual rehabilitation and amblyopia therapy can pose significant challenges in these patients. So this is a characteristic Down species with mongolite slant, broad flat nose, epicanthic folds, short nose, and sandal gap in feet. So coming to the materials and method, this was a retrospective case series which included 44 eyes of the 22 patients with Down syndrome. The study was done at RP Center, AIMS. All patients of Down syndrome were operated under general anesthesia, and ethical clearance was obtained from Institute's Ethics Committee. It was a retrospective study, so medical records of all the cases were evaluated. And parameters such as gender, preoperative distance, visual acuity, presence of strabismus, nystagmus, cataract morphology, these were taken. Visual acuity of the patients were recording according to age-appropriate methods and capability of these children, as most of these children were mentally retarded. Antenatal history, careful history of surgical notes, all were taken. So coming to the results, a total of 44 eyes of 22 patients with Down syndrome and cataracts who underwent surgery under general anesthesia were included in the present study. The mean age at the time of surgery was 10 years. Most of the patients were pediatric patients, less than 2 years, 54%. Only 2 patients were adult patients. All patients presented with bilateral cataract. All patients had developmental delays. 12 patients had congenital heart disease, and 8 patients had a history of thyroid-related problems. 27% of the patient had a history of premature delivery, and 18% had oligohydramnios. Most of the patient had 59% had LSCS delivery. So coming to the associated ocular condition, nystagmus was present in 24 eyes, strabismus in 5, keratoconus in 16, corneal scar in 2, and microcornea in 2. Coming to the presenting complaints of the patient, most of the patient presented with white reflex in 50% of the patient. Diminution of vision was complained by parents of 18.1% patient, abnormal eye movement in 18.1%, and inward deviation in 13.6%. Coming to the morphology of cataract, most common morphology noticed was jonular cataract, which was present in 50%. Other were total white cataract, cerulean cataract, blue dot cataract with posterior subcapsular cataract, anterior subcapsular cataract with posterior subcapsular cataract, and MSC was present in two eyes of adult patients. So these are the morphology. Most common morphology, jonular cataract, and rightmost side we can see the total white cataract. Coming to the surgical part, the surgical technique was modified depending on the age of the patient. In all pediatric cases, the cataractous lens was removed and posterior continuous capsular axis with limited anterior vitrectomy was performed. Lens aspiration was performed in 90.9% eyes, and 4 eyes of the adult patient underwent phacoemulsification. In pediatric patient, a second eye surgery was performed after 3 days. 2 adult patients underwent a second eye surgery after 6 weeks. The decision to implant an intraocular lens depended on the age and biometry of the patient. Children less than 3 months of age with axial length less than 17 mm were left aphakic. An intraocular lens was placed in 90% eyes, and 4 eyes were left aphakic. In 2 eyes, a multi-piece intraocular lens had to be implanted due to intraocular PC rupture. There was a subjective gain of vision in all the patients. Only 2 patients were able to perform objective visual acuity test on follow-up. An objective assessment of visual acuity was difficult in these patients due to their intellectual disability. Now coming to the intraoperative finding, poor pupillary dilation was noticed in 6 eyes, thick PC plaque in 10 eyes, partially absorbed cataracts, anterior and posterior fluid collapse on ASOCT was present in 4 eyes, white dot sign was present in 2 eyes, pre-existing PC defect was noticed in 1 eye, pale disc was noticed in 2 eyes. So coming to the post-operative care, all the patients were on topical moxifloxacin, prednisolone phosphate 1%. Homeotropin was started in pediatric patient, and topical tropicamide 0.5% was instilled in adult patient. So now coming to the conclusion part. So cataract surgery in Down syndrome is challenging due to associated systemic condition in this patient, and also post-operative visual rehabilitation can be challenging due to poor compliance of these patients. So and also American Academy of Pediatrics recommend ophthalmic examination within 6 months of birth in children with Down syndrome, and 1 to 2 yearly examination to detect any associated ocular pathology. Thank you.
You mentioned in your slides that in pediatric cases, second eye surgery was carried out after 3 days. What do you mean by that? You're presenting in a scientific forum. Secondary surgery means what? You have to specify what was done. Why were all of them operated again after 3 days? That means you gave them GA again after 3 days?
Sir, bilateral pediatric patient, first eye was operated on day 1, and after 3 days, this is the standard protocol which we follow at our
No, you
institute.
didn't mention that. If you just go back to your slide. In your slide, you said you've not mentioned. Then probably I think it was not written correctly
Yes,
there.
sir.
Okay. The other thing is nice presentation.
Okay.
Down syndrome cases, I think all of us know, we have dealt with them. They are normally complex cases. It is very important to get a complete physical evaluation done first, pediatric consultation,
Yes.
genetic consultation, and ultimately then they come to us. And more important than the surgical part he has done, more important than that is the follow-up part to ensure that if amblyopia is there, it is corrected or you prevent amblyopia from
Most
developing.
of the patients are lost to
So,
follow
but
up.
nice long series you have, good.
Thank you, sir.
Good presentation, Dr. Vishal. And may I request Dr. Ms. Alisha Kulkarni, please. Her paper on profile associated with types of inflammatory profile with cataract.
HDMI नहीं है अच्छा पूर्ण नाही येते म्हणजे तिकडे स्क्रीनवर
फुल स्क्रीन नहीं है सर जी
हे असंच राहू दे मला पाहिजे Can I start, sir? Good morning, all. Today I will be presenting on the novel immune signatures and inflammatory profiles associated with types of cataract. I have no financial interests. Till not very long ago, cataractogenesis was thought to be due to oxidative stress and osmotic stress, which eventually led to lens protein modification and aggregation. But what if the altered immune profiles that play a role in cataractogenesis and more specifically in different types of cataract? Based on a few studies done on animal models, we asked ourselves if there are any molecular factors altered in eyes with different types and grades of cataract, and if they were proportionate with the cataract types and grades. Till recent times, the adult lens was thought to be an immune-privileged structure protected from inflammatory responses, as it is not associated with any vasculature. However, it has now been established that novel pathways exist by which the immune cells associate with the lens to protect, maintain homeostasis, and repair it. The lens harbors a population of tissue-resident immune cells, which are often seeded during the early lens development phase. Studies reveal that the ciliary body is the principal source of lens-resident immune cells. After cataract surgery wound, these activated immune cells proliferate and rapidly populate the wound edge. These cells secrete CD44, CD45, CD14, MHC2, and most importantly, vimentin and integrin. This study by Ehsan et al. Identified two distinct routes of immune cell trafficking in the eye pertaining to the cataract formation. The main route originates in the ciliary body and the alternate through the pre-retinal conical structure or its immediate vicinity. In our study, we included all cataract eyes and were subdivided into groups depending upon the grade. Aqueous humor was collected during standard of care cataract surgery. The cell-free part of the aqueous humor was used to measure the soluble factors like cytokines, chemokines, and growth factors. And the cells in the aqueous humor were measured using immunophenotyping. Coming to the results, out of the multiple immune inflammatory factors measured, the levels of vascular endothelial growth factor A, interleukin 6, and interleukin 17 were significantly raised. Both interleukin 6 and interleukin 17 levels were significantly raised in nuclear sclerosis of grade 3 to 4 with posterior subcapsular cataract. Higher levels of leukocytes, total neutrophils, and activated neutrophils were observed in posterior subcapsular cataract alone. However, monocytes, cytokine-producing NK cells, and T cells were higher in nuclear sclerosis along with posterior subcapsular cataract. These findings demonstrate that cataract type-specific immune cell and inflammatory factors diversity is present. Our study adds that the immunoinflammatory profile of posterior subcapsular cataracts is distinct from other types, underscoring the importance of immune-mediated mechanisms in cataractogenesis. The variations in inflammatory markers and immune cell populations suggest that cataracts are not merely a result of aging, but also involve active immunological processes. Identifying specific immune signatures in different types of cataract may enable targeted anti-inflammatory therapies to slow cataract progression, personalized surgical management to minimize postoperative complications, and better prognostic tools for assessing the risk of post-surgical inflammatory responses. Finally, a larger cohort study to validate our proof of concept data and further studies exploring the mechanistic pathways of inflammation in cataractogenesis, which may pave the way for novel therapeutic interventions which ultimately improves the patient outcomes in cataract surgery is required. Thank you.
So we all know that cataract is also age-related versus the posterior subcapsular, which you told is a result of inflammation, drug-induced, other things. So what was so specific regarding, because we all know that cataract is due to inflammation, uveitis, diabetes, and so other things, especially in posterior subcapsular. So one thing we came to know that there are certain markers which are more so are present there, which anyway we thought that these are, for example, in diabetes or inflammation or in uveitis, they would be there. So any specific thing in your study which told that in relation to nuclear and cortical cataract, which are usually age-related, you find that some sorts of markers were more present in nuclear and cortical cataract?
So first of all, in our study, we have excluded all patients with diabetes and complicated cataracts. These are all only plain age-related cataracts, and we have not included any cataract which is due to any uveitis or retinal disorders or any patients on any systemic diseases. So that rules out any confounding factors. And in these patients with only cataracts, age-related cataracts, we have found that there is significant increase in immune cells and inflammatory markers in posterior subcapsular cataract, which are not as increased in other types of cataract.
So any particular reason for increase in immune cells in such kind of patients? Could you make it out? It was just age-related only.
Yes.
Actually, in posterior subcapsular cataract, even if there is no evident manifest pathology, generally it is assumed that posterior subcapsular tends to be secondary to some underlying condition which may not be manifest, which may be subclinical. So I think it stands to reason your
Yes.
study supports that.
Yes, sir.
And like you said, this is just the initial thing, and probably it can lead on to
More
further
studies,
studies,
yes.
and then let's see how things work. But good presentation. Thank you.
Thank you, sir.
So the next presentation is by Dr. Manendra Singh. Is he here? Dr. Manendra Singh is not. So we move on to the next speaker is Dr. Naren Shetty from Narayana Nethralaya, and he shall be speaking on novel biomarkers to predict anterior capsular fibrosis and possible therapeutic intervention. Manendra? Okay. So Dr. Manendra is here. You are from Emerald Medical College?
Yes, sir.
Okay. So his topic is to correlate between pentacam nuclear density grading and LOX3 grading in senile cataract.
Can I start, sir?
Yes, yes, sure.
Good morning, everyone. I'm presenting my topic on correlation between pentacam nuclear density and LOX3 grading in senile cataract. Since the cataract is the global health issue, and particularly among the adults, and is caused the major cause of reversible blindness in the worldwide, so the early diagnosis and appropriate therapeutic intervention is necessary to control the burden of the disease. There are several risk factors for the cataract, including the increasing age and exposure to ultraviolet radiation. Other is steroid exposure to long-term steroid and oxidative stress, obesity, and smoking. So for the evaluation of cataract, we are using from the LOX3 grading system, which consists of slit lamp imaging, which include the nuclear cataract in 6 graded on the basis of color and opalescence, and the cortical and posterior subcapsular cataract into 5 grades with the help of retroillumination images. By the pentacam, it is a non-contact device, so we can image the 3-dimensional images in just a second, and hold the 3-dimensional images of anterior segment, and lens is imaged, and it is based on Simpling imaging system. So in this, there is a pentacam and LOX3 system. In this LOX3 system, we have a nuclear, on the basis of nuclear color and opalescence, there is 6 graded, and in the pentacam, we have 3-dimensional images of the whole lens. So we can grade according to the opacity of the lens into the 5 stages. This is the same picture that patient have nuclear sclerosis grade 5, and in this there is a pentacam nuclear density which evaluate the patient with nuclear opacity. This was a prospective interventional study which is performed at the RIO Prayagraj, which is tertiary care center associated with MLN Medical College. The inclusion criteria include the patient with age more than 50 years and patient with the senile cataract, and exclusion criteria is patient with corneal opacity, glaucoma, pterygium, ocular trauma, ocular surgery, abnormal pupil or iris, and vitreoretinal disease. After explaining the procedure and pre-operative workup, that is uncorrected distance visual acuity and corrected distance visual acuity, and the non-contact tonometry for the IOP, and slit lamp examination, fundoscopy, specular microscopy, and IOL master for the biometry. And this slit lamp, the cataract grading was performed with the help of LOX3 and Pentacam. Coming on to the result, the demographic data include the there is the high prevalence in patient with age more than 60 years, and LOX3 grading and Pentacam nuclear density grading was almost similar. That is grade 2 in 38% cases of 38% cases, and Pentacam nuclear staging was grade 2 in 43% cases. This is almost similar. And the according to the Pentacam nuclear density, there is a percentage endothelial loss after the post-operative cataract surgery. In there is a strong positive correlation between the total cumulative dissipated energy and endothelial cell loss. That is, if there is increase in CDE, that is increased loss of endothelial cells, and there is a strong positive correlation between the Pentacam nuclear staging and LOX3 grading. The Pentacam nuclear density is also strongly positively correlated with the cumulative dissipated energy of the phacoemulsification. So the current study was conducted to evaluate the correlation between Pentacam nuclear staging and LOX3 in cataract grading to determine the relationship between the Pentacam nuclear staging and cumulative dissipated energy and endothelial cell loss. The present study include the study subjects of more than 60 years, which was age-related of non-modifiable risk factor. And in our study, we found that about 60% of the patient were female. It is due to the estrogen withdrawal effect, or after menopausal, there is increased risk of cataract. In our study, with the Pentacam nuclear density of the study subject increases significantly with the increase in the grade of LOX3 grading of the lens opacity with correlation coefficient of 0.948 with p-value of 0.01, which suggests that there is a strong positive correlation between LOX3 and Pentacam nuclear staging. This similar study was performed, and they have found showed the correlation coefficient of 0.845 and 0.765 at p-value of 0.01 respectively. There is a strong positive correlation between the Pentacam nuclear density by the and the cumulative dissipated energy. This finding was similarly that is the study conducted in Chandigarh, India by Gupta and all, and so there is linear positive correlation between Pentacam nuclear staging and cumulative dissipated energy. The proportion of intraoperative and postoperative complication of phacoemulsification surgery among the respective participant was identified as 6.6% and 11.6% respectively.
Your time is up. Please try to wind up.
Yes. So by the modification of the surgery, there is a less post-operative complication as observed in the previous studies. One patient has a posterior capsular rupture which was managed, and with the anterior vitrectomy and PCIOL implantation was done, and one patient has intraoperative iris prolapse which was managed successfully with the low vacuum and low irrigation flow.
Please conclude, otherwise we'll have to switch it off.
One patient has post-operative descent folds and edema, so AIOS0225 was found and dyspeptopexy was done. So the conclusion in this study is we found that LOX3 staging is a significant positive correlated with to the Pentacam nuclear density. By the Pentacam nuclear density, the exact density of the nucleus can be determined, which help in removing the subjective bias of the LOX3, and it is less time consuming. The study evaluated the positive correlation between Pentacam nuclear density and CDE and LOX3 system. In this study, we have found that less endothelial cell loss by the modification of surgical technique according to the preoperative evaluation. Thank you.
Thank you, Manindra. The only concern is your study was regarding the grading of nuclear.
Yeah.
So why did you bring in the endothelial cell loss in those cases?
Sir, in these cases, sir, nuclear densities are evaluated, and the preoperative modification was done. Stop and chop technique or pre-chop technique was done to.
But was that a part of your study? Your aim was not to see what will be the loss of endothelial cells. Okay, thank you.
No, even otherwise, you see, if you are in a higher institution where you have all the equipment available and residents available, it is fine just for doing it, you do it. Otherwise, what does it add to your this thing? With LOCS, surgery has been going on for ages. How will this add to anything? I mean, what additional help does it give you in surgery? It is a good thing that, okay, you've done it, sort of corroborates and all that. But there has to be, do you know the cost of pentacam?
Yes.
So just to classify cataract, I think if you ask somebody to get a pentacam or get a pentacam scan done, I don't think it is justified.
They
But
must be
fine
having a
for a,
pentacam for some
that's
other
what
thing,
in a institution where it is there, it is fine with PGs you do it. But it is not something which can be added as a routine armamentarium that you do a pentacam in every case to decide the density of the nucleus. Thank you.
Thank you.
I will invite Dr. Naren Sethi. His topic is novel biomarker to predict anterior capsular fibrosis and possible therapeutic intervention. Dr. Naren Sethi.
Good morning, everyone. First, I would like to thank AIOS and APAO for giving me this opportunity. I have no financial disclosures. Now, one of the key things for a successful surgery or to prevent complication is to have a perfect or a complete rhexis, or basically a CCC. But when you have anterior capsular fibrosis, it can be really challenging to complete the rhexis. You can have rhexis extension, PCRs, lens drops, and so on and so forth. So the research question was, can we actually predict which patients or which eye can develop anterior capsular fibrosis? So for this, we did a study where we tried to identify biomarkers in tears and aqueous, which contribute to the formation of anterior capsular fibrosis. This was the inclusion and exclusion criteria. Basically, we excluded pediatric cataracts. And we had a sample size of 100. 50 eyes were anterior capsular fibrosis, 50 eyes were normal anterior capsule. And regular cataract workup was done. AS anterior segment OCT was done. Tears was collected preoperatively, and also the aqueous was collected intraoperatively. Follow-up was done at day 1 and 1 month post-surgery. Now, if you look at the results, we found novel altered metabolites in fibrous capsule as compared to normal cases. And as you can see, there is a significant downregulation of antifibrotic factors, especially the most important being the harmaline. And the next question which came into our mind was, which these antifibrotic factors, which pathway does it really affect? So we identified it to be TGF-beta pathway. And the next question which came into our mind was, can we actually identify drugs which are already there in the market, which can act on the same pathway? So we did identify certain drugs which act on the same pathway, but the most interesting was the Trehalose. Trehalose, as you know, I think all of us have been using in our clinics as a lubricant, and it's widely available and easily accessible to anybody who's practicing. So now we have identified novel biomarkers in anterior fibrotic capsules, but how do we use this in our clinics, which is more important? So the next time we see a cataract patient, we can collect the tears, put it in basically into this small compact diagnostic device called as Biopath Finder. Basically, it works on the principle of multiplex ELISA assay. And within 90 minutes, you will have a report in your hand. Now, if the patient has fibrotic capsule biomarkers present, then you can ask the patient, look, you have this high risk of developing it. Why don't you go for the surgery early? Now, if the patient is not willing for the surgery early, then you can tell, okay, look, you can put the Trehalose eye drops till the time of surgery so you can prevent the anterior capsular fibrosis from occurring. That way, you prevent the complications that normally occurs in a fibrotic capsule, and also you make the surgery so much more safer and you deliver much better outcomes. So what was known was anterior capsule becomes fibrotic, and due to unidentified causes, fibrotic capsules can lead to difficulty and complications during cataract surgery. What our study adds is, for the first time, we have shown identified novel altered biomarkers and also the key fibrotic pathways involved in it, like TGF-beta. And we have, with the help of these biomarkers, we are able to stratify the individuals at risk, and also we highlighted promising drugs like Trehalose that could aid in preventing anterior capsular fibrosis. Thank you so much for your time.
So thank you. So few questions which come into my mind is, one is, could you demonstrate that Trehalose really decreases the incidence of, see, finding one thing is that marker is okay, fine. But could you demonstrate that Trehalose does decrease the incidence of progression of anti-capsular fibrosis?
Yes, so what has been already established and published now, sir, is the Trehalose works against, downregulates the TGF-beta pathway. That has been already published, sir.
Okay.
The whole point is, till now, the cause of the downregulation of anti-fibrotic factors wasn't discovered. So nobody knew what was that pathway that the fibrous capsule was occurring. So now we have identified these aspects. Since this has been already established, the next step is to see how we can actually prove it, in patients that it actually doesn't occur when we identify these fibrotic capsules.
No, my only concern is, until unless you have some study,
Yes, sir.
let's suppose in 100 patients, 50 with the same group, 50 with other, and in one eye you start with Trehalose, in other eye you don't start with Trehalose.
Absolutely, sir. It has to be done.
Yeah,
Has to
until
be
you have
done.
proved, you
Absolutely,
cannot
sir.
tell to the patients to start doing this, number
No,
one
absolutely,
thing.
sir.
And second thing is, you told that you take out some amount of tears, and then you see. So aqueous and tears are completely different. So how would you identify that the presence of this in tears would actually lead to anterior capsular phimosis or not?
Yeah, that's what, sir. So we did identify in this study,
Yes.
we have collected both, the
Yes.
tears and aqueous. This
Yes.
is just for the study purpose because we analyzed both the tears. So what we have shown is that from the tears itself, it being a non-invasive way of collecting, so that we don't need to do surgery and then identify, okay, this person had the risk. So then it'll be not much of use. So that is why we have tested the tears too in these patients.
The
so
question
that we can
is
do it, sir.
that the increase of this substance in 3 years versus the increase in aqueous humor, was it proportionally greater as compared to those
Tears,
patients?
normally biomarkers are much more larger, more pronounced, sir. It's more louder
As compared to
as compared
aqueous.
to the aqueous, yes, sir.
So, and malab, in both the groups, in groups which had anti-capsular phimosis, the this beta whatever is there was more in the group
Fibrous capsules. sir.
fibrous
yes,
capsule.
Yes, sir. Yes, sir.
Okay.
Dr. Naren, actually, preoperatively, comparatively, we don't see that much of anterior capsular fibrosis, right? We are more concerned actually about capsular phimosis post-surgery. So did you follow up these cases who have some degree of anterior capsular fibrosis? Post-operatively, how do they behave? Are these, they are more prone to develop capsular phimosis? And did you correlate it with other findings, like say in pseudo-exfoliation and all, where you know that fibrosis
Right,
and phimosis occur?
No, absolutely, sir. I think that is something that for this study we didn't look at, sir, because that wasn't part of the objective. But that is a very interesting point which we can look at.
Actually, see, the
sir.
post-op is something that we are more concerned about because
Absolutely.
pre-operatively, even if some degree of, unless of course, gross capsular fibrosis is a different story, but minor amounts of capsular fibrosis, even if they are there, not very difficult to manage. But it will be a very good thing if
Absolutely.
further
No,
studies can be
absolutely.
carried out and you can identify that a simple
Absolutely, sir.
drops,
Absolutely.
eye
And
drops
like you
can
said,
actually prevent that.
And like you said, sir, that if you have a higher, down-regulation of antifibrotic factors, and then you do surgery, they have a higher risk of post-operative,
So if you can
they're not
prevent
developed.
that,
also.
they'll be better off
Absolutely,
post-op
sir.
also.
Absolutely,
So-
sir. Absolutely.
So a good start. Let's see how things pan out. Thank
Thank
you so much.
Thank you, sir. Thank you.
Next. Next, Bilal.
Dr. Tanmay Vaidya. Yeah. Capsular phimosis and retinitis pigmentosa, role of capsular tension ring, polishing and biomarker analysis.
A very good morning to everyone here. So I'm Dr. Tanmay Vaidya. I have no financial disclosures. So retinitis pigmentosa is a group of inherited retinal disorders having visually debilitating symptoms. But one of the most important factors here is the early onset posterior subcapsular cataract. And surgeries in these patients can be a blessing because their central vision can maybe restored as long as the macula is fine. But the only problem, the long-term post-operative side effects may be higher, and one of them is capsular phimosis. It is also proposed that zonular dehiscence in these patients and increased lens epithelial cell fibrosis may be the reason. And in these cases, it's early onset and it's very aggressive. We can see an image here where literally the lens has been crumpled up inside the bag itself. So we decided to conduct a study to assess the role of a capsular tension ring and anterior capsular polishing and to see if that prevents this capsular phimosis. And we also analyzed the levels of biomarkers in these patients. So we included patients having bilateral immature cataract, having retinitis pigmentosa. We excluded the complicated cataracts and any other ocular comorbidities. we conducted a prospective interventional study after the ethical committee approval. We recruited 20 patients, that is 40 eyes, having cataract with retinitis pigmentosa. After carrying out a detailed examination and the ancillary investigations, we performed the cataract surgery in the first eye with the capsular tension ring and the polishing, and the second eye without the intervention. And during the surgery, the aqueous humor was also collected. The follow-up of these patients was done after 6 months. So like I said, the aqueous humor was first collected before the cataract surgery, like during the cataract surgery. That was the first step we did. We also placed the CTR, and the anterior capsular polishing was done in the first eye, and in the second eye it was not done. The assessment of this capsular phimosis was done after 6 months on a slit lamp examination, where we measured the diameter of the inner extent of the capsular phimosis and we calculated the area. So anterior capsular contraction or phimosis was considered when this diameter of either meridian was less than 3.5 millimeters, corresponding to an opening area of around 10 millimeters square. After doing this, the aqueous humor which we had collected, we sent for multiplex ELISA and we did flow cytometry, assessing the following biomarkers. Now what we saw was very interesting. After 6 months, only one patient showed significant capsular phimosis where we had actually done the intervention, whereas where we had not done any other intervention, 5 patients developed significant phimosis. And it was approaching statistical significance. One of the most important factors is understanding exactly why it is occurring. Now I would like to show the SLCAM1 factors here, which are grossly increased in retinitis pigmentosa. Now this is the same factor which is found in cystic fibrosis, that is in the lungs. And a lot of research has also been carried out in these areas. Along with that, the VCAM factor 1 and the granzyme was also increased. These are all the biomarkers which are found in systemic diseases like cystic fibrosis or even in other musculoskeletal disorders. We also saw a lot of factors decrease, like the protective factors like PDGF-A and PDGF-B. And along with that, perforins were also reduced, which are anti-fibrotic factors, along with the interferon beta. So, as I said, there's a synergistic environment which is created where the pro-fibrotic factors are increased significantly and the anti-fibrotic factors are reduced. This is what actually causes the aggressive capsular phimosis. Although this was not exactly one of the objectives of this study, but we also observed that in early RP changes, the capsular phimosis is not very aggressive. And in these same patients, we also incidentally saw the borderline values of these biomarkers. But with advanced cases, these factors, especially the pro-fibrotic factors, were increased. And in these patients, the phimosis was seen. So in conclusion, what was known is that there is early onset in cataract in RP. And also cataract surgery improves the quality of vision, but capsular phimosis is one of the factors which may cause an issue. What this adds is the CTR and capsular phimosis, capsular polishing may reduce the incidence of phimosis, and there is increase of pro-fibrotic factors and reduced anti-fibrotic factors, leading to its increased incidence. In the future, lot of targeted therapy which may be carried out. So already drugs are available which are there, like perfenadone, which is used in cystic fibrosis. We can use these in the future to prevent the capsular phimosis. Thank you.
Exactly in time. So one thing is, there are two things which I think is important. One is when you are measuring the anterior capsular phimosis, so you should also note down what was the rhexis margin initially.
Yes.
So that you know what is the deviation from that margin to this,
Yes,
rather than only the absolute value.
Yes, sir. I should have included this in the slide, but our study excluded the patients where the rhexis margin was less than 5 millimeters. And it was carried out by a single surgeon.
Yeah.
I should have included.
So you have to say that from 5, it went to 3 or whatever it is.
Yes.
The another point was that you have included both the things. One is anterior capsular polishing and one is insertion of CTR. So we don't know what was the main reason for decrease in that. So a good study would be, a better study would be to classify into 3 parts. One is only with capsular tension ring, one is with only polishing, and one would be with both, and you can increase the sample size for the same.
I feel, sir, only issue in these patients, like in these kinds of studies, that the number of RP
Sample size.
patients,
I know.
It's very difficult to get, so we had to group it together.
Yeah.
Yes.
Okay. Thank you.
Sir. Thank you.
Actually, since you have all these facilities available in your center, I think you can do a prospective study on patients who actually develop capsular phimosis, irrespective of whether they have pseudo-exfoliation or RP or whatever, and then see if there is a common factor amongst them.
One more thing which
With
we
all
have
the study
seen
that you have.
that earlier when we were using hydrophilic lenses, this capsular phimosis was much more as compared to the hydrophilic because they are stiffer and stronger as compared to hydrophilic lenses.
Yes.
Thank you.
Thank you, sir.
Our next speaker is Dr. Pavitra Patel on UFO sign.
आप कर रहे वहाँ से? मैं करूँ ना यहाँ से?
Timer restart कर दो. Just reset the timer. Yeah, please start.
Yeah. Good morning, everyone. I'm going to present my free paper on UFO sign, vitreous lens interface changes after phacoemulsification with different infusion pressure settings. I have no financial interest. So Burgess space is a space which is located between the posterior lens capsule and the anterior hyaloid of the vitreous.
Just 1 second, ये full screen क्यों नहीं आ रहा है? Okay, just carry on.
Again?
No, please carry on. It's not coming full screen.
इधर भी नहीं आ रहा.
यहाँ भी नहीं आ रहा, ठीक, what is wrong?
Just wait, है ना?
Yeah.
Just full screen
No,
कर
it's
दो.
okay.
और फिर restart the timer.
Notes हटा दो.
Yes.
Yeah,
Restart the timer.
हो गया, हो गया.
Okay.
Yeah, now you can start.
Restart, हाँ.
Good morning, everyone. I'm going to present my free paper on UFO sign, vitreous lens interface changes after phaco with different infusion pressure settings. I have no financial interest. So Burgess space is a space which is located between the posterior lens capsule and anterior hyaloid of the vitreous. And the Weger's ligament is an attachment which is present between the posterior lens capsule and the anterior hyaloid face. So using the Centurion machine with active fluidics, we can operate at various different infusion pressures ranging from 20 to 110 millimeters of mercury. So what are the advantages of operating at a low IOP setting? Basically, operating at low infusion pressure mimics the physiological IOP of the eye and hence increases the patient comfort level. It also enhances the chamber stability and minimizes surge. There is abundance published literature which tells us the benefits of operating at low infusion pressure. But is it true that a low intraocular infusion pressure results in less disturbance of the anterior hyaloid face? This came to the research question of to determine using AIOS0225 whether varying infusion pressures used during phaco may have a detrimental effect on the anterior hyaloid membrane barrier post-operatively. So the age criteria was 50 to 70 years of age. It was a prospective randomized study where the patients were divided randomly into two groups, 150 eyes in each group, and this was the inclusion and the exclusion criteria of our study. So the preoperative assessment was like any other cataract surgery. It included specular microscopy as well. And all the surgeries were performed by the same surgeon using Centurion machine with active fluidics. So the fluidic parameters were similar in both the groups except for the IOP setting, which was 20 in group 1 and 80 in group 2. Intraoperatively, pain was assessed using Wong-Baker scale, and postoperatively, UDVA, CDVA, specular microscopy, and SDOCT was done to assess the Burgess space. Now on AIOS0225, one can see the anterior and posterior surface of the IOL, the posterior lens capsule, and the anterior hyaloid membrane, and the space between these two structures was known as the Burgess space. Now coming on to the results, there was no age difference between the two groups. Also, there was no statistically significant difference noted between any of the biometric parameters. This shows a statistically significant difference in the pain perception among the two groups, with a better pain tolerability in group 1, which had a low IOP setting. Now, at 1 month, there was statistically significant difference noted in UDVA between the two groups. About 10% of the patients in group 2 had UDVA less than 6/6. Similarly, a significant difference was noted in MRSE between the two groups. Now, there was no significant difference noted in the post-operative inflammation as well as the endothelial cell loss at 1 month in both the groups. Now, in our study, 3 eyes showed positive Burgess space in group 1, whereas 82 eyes showed positive Burgess space in group 2, where a high IOP setting was used, and the difference was significant. Now, out of the 82 eyes who had a Burgess positive space, we now wanted to see whether this space was symmetrical or asymmetrical. So, 15 eyes had symmetrical Burgess space. 65 eyes showed asymmetrical Burgess space with a maximum width opposite to the site of the main incision, and 5 eyes showed asymmetrical Burgess space with the maximum width below the site of the main incision. And the significant difference was noted. So because of the striking resemblance of the positive Burgess space in patients with high infusion pressure on AIOS to a UFO, we coined the term UFO sign. So what is the pathophysiology of this Burgess space? This is the normal anatomy, what we see pre-operatively. Now, post-operatively, what happens is, because of the high impact of the infusion irrigation fluid flow in high IOP setting, it may cause a local crevice here, as you see in the Wiegert's ligament, resulting in local anterior hyaloid detachment. And we speculate that the Burgess space width is related to the extent, it tells us the extent of the Wiegert ligament damage, and higher the Burgess space width, more the damage of the Wiegert ligament. So the Wiegert ligament rupture can cause excessive Burgess space hydration during phaco, leading to anterior displacement of the IOL back complex, increasing the risk of refractive surprise, and can sometimes lead to aqueous misdirection syndrome as well. So to conclude, use of the UFO sign on ASOCT is a reliable tool to detect the occurrence of positive Burgess space in patients undergoing phaco with high infusion pressure. What new does this study add? Use of ASOCT for predicting Burgess space, to demonstrate positive Burgess space in different infusion pressures and correlating of this positive Burgess space with refractive surprises. How do we translate this into our clinics? You adjust the ratio between the bottle height and flow rate to achieve the balanced state. And this enhances the stability of the fluid circulation and safety during surgery, and always preferable to operate under low IOP settings. So how do we overcome the limitations? Use of SSOCT instead of SDOCT for better penetration, and longer follow-up periods to observe the morphology of Burgess space. Thank you.
Thank you. You told anterior dislocation or posterior dislocation of the?
Anterior dislocation, because the hydration of the Burgess space, the posterior capsule will go higher. So that will result in anterior displacement of the whole IOL back complex.
Why can't it be posterior displacement of the anterior vitreous phase?
The Burgess space is below the posterior capsule. So
Yes.
if it hydrates, if it increases in
so
the
it
width.
can go downwards also, that inferior margin.
Yeah, but the posterior capsule is right above the Burgess space. So that posterior capsule, because of the push from the from below, because of the hydration of the Burgess space, in our study, it showed the anterior displacement, because of which 10% of the cases in our study showed a mild refractive surprise, because of which the vision did not improve to 6/6.
Thank you.
You operated on low IOP and versus high IOP.
Yes.
Low IOP was 20.
Yes.
The machine was working on 20?
Yes, this is a Centurion machine
Yes,
with active fluidics.
Centurion machine, even at the 20, you know that you have to wait longer to remove that visco from whether it is methyl cellulose or anything else. You have to wait longer to remove that.
So we use HPMC, sir, so there's no problem in room, because I've been operating in Centurion since last 5 years. Initially, I used to operate in high IOP setting because that was my beginning stage. But gradually, I started lowering the IOP. I could see the refractive surprises going down. And then, obviously, it takes a little learning curve. But then once you are used to...
Because I'm sharing the experience, I'm using Centurion from last many years.
Okay.
So my personal experience is that it should be somewhere around 26 to 28.
Okay.
No, sir, actually the Century active fluidics, I have operated at 20 millimeter. I've done more than 20 cases in one OT. So it's not a difficult thing. With the active fluidics, it tends to maintain the anterior chamber.
Yeah.
So that's my experience, sir. Thank you.
Thank
you
you
so much.
Next one.
Next is Dr. Gopal.
A very good morning to one and all. I'm going to be presenting on systemic emergencies, a roadblock to cataract surgery. In India, 71% of visual impairments and 66% of blindness among individuals aged 50 years and older is due to cataract. Phacoemulsification under topical anesthesia is the preferred choice of treatment for cataracts. This is due to the reduced intraoperative systemic complications. However, in the elderly population, due to the systemic conditions like diabetes, hypertension, cardiovascular disease, or chronic kidney diseases, there is an increased risk of these complications like pulmonary edema, myocardial infarction, and anaphylaxis. Though the primary focus of cataract surgery is ocular outcomes, however, systemic health can never be overlooked. To undermine this, we have done a study to determine the overall incidence of intraoperative medical complications and identify the relevant clinical parameters. This was a retrospective observational study done in a tertiary care eye hospital in South India. 5 years of data was collected from January 29 to December 2023. The data was retrieved from electronic medical records. So those patients who had a systemic emergency during cataract surgery were included, and those who underwent combined procedures or when the surgery was done in general anesthesia were taken out of the study. During the preoperative evaluation, we did a thorough history taking of the systemic condition. The vitals were recorded and necessary blood investigations were ordered. After physician clearance, on the day of the surgery, patient's vital signs were assessed before shifting the patient to the OR, and an intravenous access was gained in the high-risk patients. On table, the pulse rate and the oxygen saturations were monitored for all the patients. So we defined a systemic emergency as when the patient complains of any breathlessness, chest pain, severe cough with crepitus on auscultation, or if the pulse rate was above 140 or less than 40 beats per minute, or if this SpO2 dropped less than 90%, or if the diastolic blood pressure shot more than 120 millimeter of mercury. In case of an adverse event, the anesthetist was promptly stabilizing the patient and was shifted to the ICU or the nearest multi-specialty hospital for further management. The statistical analysis was done using Strata 17. Coming to the results, 4,43,712 cataract surgeries were done during this period, and 20 cases had systemic emergencies. Looking into the age group, the study population fell between 44 to 79 years, and our study showed a slight female predominance, accounting for 65%. Of the 20 patients, almost 17 people had at least one systemic condition, in which 11 of them had more than one systemic conditions. The various adverse events that we saw were pulmonary edema, myocardial infarction, atrial fibrillation, angina, and allergy. Pulmonary edema was the most commonly documented systemic emergency, with 14 patients having pulmonary edema. 11 of them had previous history of systemic conditions, systemic hypertension or cardiac diseases. The p-value was significant. Looking at the parameters, we compared the physiological parameters between the pulse rate, systolic blood pressure, diastolic blood pressure, and the oxygen saturation in aborted cases versus completed cases. The p-value was significant, indicating that these parameters must be overlooked, and these will help in giving the surgical outcome. Visual outcome, in the cases of completed cases, the visual outcome was better, whereas in the aborted cases, the visual outcome was not as good as seen. We did not find any significant correlation between the anesthesia type or the waiting time or the surgical duration with the development of systemic complications. Going into the discussion, like I told, for the 4,43,712 cataract surgery, 20 cases had systemic emergencies, of which 10 were aborted midway to stabilize the patient systemically, and 2 patients underwent successful resurgery. Pulmonary edema was the most commonly observed systemic emergency. 85% of them had at least one systemic illness, and there was a 50% cancellation rate and all of them needed ICU care. There were no fatalities documented, and the completed cases had a better visual outcome. We did not have many studies related to this. Whatever were available, most of them did say that there is chances of systemic complications occurring during cataract surgery, and they must never be overlooked. Limitation, the sample size was pretty small, so we couldn't find many risk factors. And looking into the future recommendations, we have to look into the pre-operative optimization of the patients with multiple comorbidities. This might prevent intraoperative complications in high-risk population. Conclusion, we must integrate systemic health assessments into routine cataract surgical planning, and we must have a multidisciplinary collaboration among ophthalmologists, anesthetists, and physicians. And we shall strengthen monitoring protocols to detect and manage these systemic complications. These are my references. Thank you.
Thank you. So you told that your sample size was small. Yeah. Out of 4,63,000 people, what do you mean to say?
She's talking about the number of complications.
Systemic emergencies.
So that systemic emergency is not your sample size.
No.
Sample size is your total size. So you cannot have more sample size of more than 4.5 lakh people. Systemic emergency is a part of those who are having this. So sample size cannot be larger than this. It's already very large sample size.
So Dr. Archana, actually a nice presentation. The thing is, this pre-operative checkup in the army, routinely we have every patient going to the OT, whether you're going to do it under topical or with the block, has to undergo a complete checkup. In spite of that, these complications occur. And I read a very nice article in Canada. There is a district where the insurance people found that before cataract, all patients were being referred to the physician, cardiologist, and they stopped paying for that. They said only blood sugar and BP is permitted, nothing else. And a 1-year follow-up showed that the number of hospital admissions for cataract cases went down. The post-op results were better because generally, since we are doing it under topical, most of the patients, like out of 4 lakh something, you had hardly about 20 all this thing. So in fact, they've stopped carrying out a pre-operative evaluation if you're going to do a cataract case, patient under topical, unless there is a known pre-existing condition for which you need a clearance.
Yes, sir.
So nice talk. Thank you.
Thank you.
The last speaker in this session is Dr. Archana Dandapani, and she's going to talk on conventional topical versus dropless therapy following phacoemulsification.
Good morning, everyone. I'm Dr. Archana Dandapani, and my study is on conventional topical versus dropless therapy following phacoemulsification. I have no financial interest. And in introduction, we know cataract surgery is one of the most commonly performed surgery worldwide, and it has evolved over a period of time, and so does the type of intraocular lens. But the post-operative care remains the same. So what were the drawbacks of topical therapy? You know, poor compliance comes the first, and dependency, self-administration problems, cost factor, efficacy issues, and safety issues. Our aim of the study is to evaluate the safety and functional outcome of dropless cataract surgery compared to the conventional topical therapy. And the outcomes assessed were best corrected visual acuity, intraocular pressure, anterior chamber inflammation, post-operative complication, and patient satisfaction. It was a randomized controlled trial conducted from June 2022 to June 2024 with a sample size of 700 eyes. They were divided into 2 groups, Group A dropless therapy and Group B topical therapy, and each group consists of 350 eyes. Inclusion criteria: patient with aged 18 years or older with visually significant and cataract and normal fundus examination were included, and patient with mature cataract, history of uveitis, glaucoma, previous ocular surgeries, retinal disorders, intraoperative complication like PCR were excluded. And all patients underwent phacoemulsification, and Group A, at the end of phacoemulsification, 0.1 ml of intracameral moxifloxacin and 0.1 ml of subconjunctival triamcinolone were given, and no medications were given post-operatively. And in Group B, routine post-operative, topical, antibiotic, steroid, and NSAIDs were given. Both groups underwent post-operative assessment at day 1, 7, 30, and 60. All the parameters were assessed by the same 2 experienced ophthalmologists for all patients in all visits. Patient satisfaction was assessed through a feedback questionnaire where patients were asked to grade the level of satisfaction with their treatment protocols, 5 being the highest and 1 being the lowest. In case of score less than 3, reason for dissatisfaction was evaluated. In results, mean age, sex distribution, and comorbidities between the 2 groups were similar, and the preoperative IOP, grade of cataract, phacoemulsification time were similar between the 2 groups. Post-operative intraocular pressure in group A in day 1 was found to be like more than 10% of patients had IOP more than 26 mmHg with mean value of 25.39, which was significantly higher compared to the group B, but it was similar between two groups in the consecutive visits. Best corrected visual acuity was similar between the two groups in all visits, and anterior-chamber inflammation was assessed by slit lamp examination, which was found to be similar between the two groups by day 30, and endothelial cell was also comparable between the groups. On patient satisfaction, group A, 96% of patients reported highly satisfied, highlighting the convenience and ease of protocol, and even highly recommended to the others. Whereas in group B, only 56 patients experienced similar satisfaction, and reason for it being the complexity of managing multiple post-operative medication, being dependent on others till the recovery, and stinging sensation and discomfort on installation of the drops. None of the patient developed endophthalmitis in the postoperative period in both groups. Subconjunctival hemorrhage was noted in 15 eyes in group A during intraoperative subconjunctival injection of triamcinolone, and two groups in group A had persistently high IOP more than 30 mmHg in postoperative day 7, where they started on anti-glaucoma medication. And 12 eyes in the group A had breakthrough inflammation for which they were treated with topical NSAIDs and cycloplegics, and all of them resolved by 6 weeks. And the incidence of postoperative cystoid macular edema was slightly higher in the group A, but although there was no statistical significance between the groups, and they were treated with topical steroids and NSAIDs, and only one eye in the group A required an intravitreal dexamethasone for non-resolving cystoid macular edema. And the effective cost of topical therapy was rupees 900 per person, and dropless therapy was 60 per person. There were multiple studies were published which was comparing the dropless therapy with the conventional topical therapy, and they have used dexamethasone implant, triamcinolone, and different route of administration like intracanalicular insert or in transzonular injection, and all concluded that dropless therapy is not inferior to the conventional topical therapy. And I conclude that our findings support the dropless protocol as a viable and patient-friendly alternative to conventional therapy, particularly in population where the compliance with topical regimes may be challenging, and future research with extended follow-up and larger multi-center trial is recommended to validate these findings and assess long-term outcomes. Thank you.
So thank you. A very interesting study. I don't think anybody of us have used this thing, but if the results are so good, and I don't think there is any harm in trying that. So how many patients did you do in this whole study?
Sir, 433 patients, but total 700 eyes. Some patients received dropless in both eyes.
Okay.
Actually, similar studies have been done even with intracameral triamcinolone. The problem is you are giving steroids which cannot be withdrawn. So in those rare cases, in case you get infection, there is end of, what do you do then? There is no way to pull that steroid back. Yes. That is the major disadvantage. Otherwise, of course, the patient is going to be happier.
Because let's suppose the patient has a steroid-induced glaucoma or something. Then what you do?
Sir, actually, we give subconjunctival triamcinolone, so we could see the depot in the patient, and we could assess the presence over the time also. Two patients only had the IOP more than 30 mmHg in POD7, for which they were started on anti-glaucoma medication like beta blocker or alpha agonist. But by 6 weeks, all patients were found to be within normal. On stopping the anti-glaucoma medication, their IOP was maintained below the 21 mmHg.
That's true, but some patients who are really very, very steroid dependent, they have very, very high, it may be less than 2% or something like that, but then it's very difficult to treat those patients when you have injected. But otherwise, it's a very wonderful study. Thank you. So I think we are at the end of, I think we had all the presentations in this session. There was not even a single absentee, and all the presentations, especially by Narayan Nitrale and this patient's presentation, were very good. So I think we should conclude this session, sir.
May I request all the speakers, there is an attendance sheet which the speakers have to sign. So can you please just take it there and sign it here. And I thank all the co-panelists and the audience for a patient hearing. I think we finished slightly ahead, just overshot by about 5 minutes. But it was a good session, good discussion. Thank you very much. Yeah, please start.
Please start.
पेन कहाँ चला गया? अब ये कहाँ गए अपने chairperson ही चले गए?
I'll start.
Yes.
Yeah, please start.
Okay. Good morning, everyone. I'm Dr. Apurva, and I'll be presenting our work on intumescent cataract. With the pioneering technology, when we operate on intumescent cataract, it poses a challenge for all of us. In spite of the multiple difficulties, the most challenging step in intumescent cataract is capsulorhexis. There are multiple studies which say that NDR anterior capsulotomy is highly effective. So when we did it in our institute, we found excellent results in some cases, as you can see in this case, where there is a significant flattening of the anterior lens surface. But another case of Morgagnian cataract, it hardly showed any difference post-YAG. Now this led to a research question, what are the anterior segment parameters which which will decide the effect of YAG, and what are the intraoperative challenges in these cases? It was a prospective interventional study. We included 90 eyes who were diagnosed as INTMAT on slit lamp examination. We excluded all cases where there was not a good scan, or they were posted for femtosecond, or it was a complicated surgery, or we noted capsular fibrosis. IL biometry was done preoperatively, and based on the classification given by Dr. Tithial et al., we classified the case on AIOS0225-Free. Type 1 consisted of regularly arranged lamellar cortical fibers. Type 2 consisted of continuous hyperreflective bands of cortical fiber with intralenticular clefts. Type 3, the clefts combined and formed areas of homogeneous ground glass appearance, while type 4 consists of uniform areas of ground glass appearance. Now, following this, all our patients underwent endothelial capsulotomy at least 30 minutes before the surgery. And following the laser, another CASIA-2 scan was done. So the parameters noted on ASOCT were the crystalline lens rise, where it is the distance between the anterior lens surface and the line joining the angle recesses, and the anterior chamber depth. Second was the anterior radius curvature. So what we found is, so this is a scan of pre and post YAG. If you look at the curvature, it has significantly flattened post YAG. And the difference was significant, especially in group 2 and 3. Similarly, before and after YAG, the circumferential lens rise has significantly decreased, and it was significant in group 2 and 3. Accordingly, the ACD also has increased in group 2 and 3. Now, when we did a multi-regression analysis, we found the three main factors which affect the outcome is the lens thickness. Now, a 1 mm increase in your lens thickness, the effect of YAG increases by almost 26 micron. Second, as we previously saw, the group of cataract, type 2 and type 3 giving us the best results, are more effective on NDR laser. The third factor is the circumferential lens rise. A 100 micron increase in your circumferential lens rise, your effect of YAG increases by almost 13.7 micron. Coming to the intraoperative challenges, we didn't notice any Argentinian flag sign, no posterior capsular rupture or nucleus drop, and in all cases, lens was implanted in the back. Coming to a conclusion, preoperative ASOCT helps in classifying and planning a cataract surgery. NDR laser capsulotomy is highly safe and effective and has no complication in our study. And the three factors which affect your effect of YAG or the CLR change is the lens thickness, your type of cataract, and your circumferential lens rise. Thank you.
Thank you. We'll go to the next speaker. So, Dr. Akansha Sharma is here. Dr. Akansha Sharma, please come. Just start your presentation. And Dr. Amog, the third presenter, is also here. Just finish in 5 minutes. Yes, yes. Actually, their presentation just stopped. I know.
If he is not taking interest to come in the time at 9 o'clock, why you are entertaining at 8 o'clock and why you are entertaining at 9:30?
Yes.
It is not right. आप बीमार करिए उनको.
Okay. Okay. So we go to the next speaker, I think, Dr. Amog. Okay. Timer is there. Late कर. इस पे भी आना चाहिए. Second वाले में just कर late है. So we move on to the third speaker, Dr. Amog.
स्विच कर दीजिए
सीट का अभी खत्म हुआ है प्रॉब्लम ये
इनको टेंशन हो गया ना
हाँ,
हमारे पास ये कागज ही आए हैं
एग्जैक्टली अभी आया है हाँ
सोमवार के बाद आए हैं
हाँ
कागज
जस्ट स्टार्ट
चलो स्टार्ट करो ये तो आ ही नहीं रहा इसमें यार क्या कर रहे हो
नहीं भी स्टार्ट लेट करके अभी ऐसे लेट कर देते हैं we are already late so just is the PPT loaded? Actually, the semi-final should be on the 3rd or 4th day. So it's. No, it's not community paper. इसके बाद आएगा. उधर मैडम को दे दीजिए.
Good morning.
Yes, yes, start. Please start.
Good morning, everybody. I'm Dr. Amog, and my talk for today is comparison of wet lab skill training in novel mobile-based VR platform versus conventional training. I have no financial disclosures. So when we pass out of residency, the main issue that we face when we go to hospitals is that there is a certain skill set that the work demands that is not available as soon as we pass out of residency. There is a certain imbalance. So how do we bridge this gap? So what are the challenges that we face in ophthalmic surgical training? One is the high cost of microscopes, the limited training access, and generally when we go to use the wet labs, there is somebody already occupying it. So the dearth of microscope is the main issue that we face, and then the institutional constraints. So what is the solution to this? We need something that gives us immersive like-to-like training and comparable, which is comparable to conventional training. So the four tenets of virtual reality would be to create an environment that mimics the OR, operating room. Second one would be the immersiveness. Third one would be feedback. And fourth one would be the intent of the virtual reality module that you're creating. So I've named the device that I've created Varda, which is after my son, which is basically virtual augmented reality developing advanced anatomical navigation. So what we have done in this is we have taken an inexpensive virtuality headset off Amazon, which is basically 500 rupees, and we have connected a Type-C to a USB connector, connected this to your normal Android phone, which is again what we normally carry around, and we have converted into a stereoscopic image. So basically single image is converted into two images, and it gives you a stereoscopic feel, which may not be two stereopsis, but which mimics very, very close to what you get in the operating room. So what makes it novel? We have a USB camera feed integration, which is connected via USB Type-C connector. We have added a plus 10 diopter PMMA length, which is again very inexpensive. You connect it to, you attach it to the USB camera to reduce the working distance. And this makes it portable and cost effective. So the study I've done has basically 20 ophthalmic surgeons, 10 beginners and 10 advanced. And we asked them to practice corneal suturing using VR and the microscope-based methods, and we measured surgical time, precision, and the surgeon feedback. So this is what we saw on comparing surgical times. It is the initial 5 minutes were given to get used to the VR headset, and then we asked them to suture. And we found no significant difference in surgical times. The advanced surgeons performed similarly, and the beginners adapted faster with VR. And then we asked them for their feedback, and we found that 80% of the participants rated the virtual reality platform as easy and very easy to use. There's a strong depth perception that was there, which is comparable to the microscopes, and there is high accessibility and affordability. This is a cost-effective alternative to expensive microscopes and can be used in wet labs. It gives a very near real experience because the plus 10 diopter lens improves the surgical precision and makes the working distance comparable. It can be taken along with you. Basically, you just have to carry the web camera and the virtuality headset, and you can basically take it to anywhere you want. It can be, the uses can be extended to squint, amblyopia. You can even record what you watch. You can actually do a virtual reality or stereoscopic recording of the, like what we do with the GoPro or a point of view cameras. Future scope would be to add AI-based feedback mechanism based on the recordings. You can actually record what you're seeing, and this can be expanded to other ophthalmic procedures. You can actually do 3D video recording, as I suggested, and do first-person view recordings and watch it later. So this is the app face front that we have developed. And this is a cost-effective alternative. It's accessible and also very good alternative to traditional wet labs. It has potential to revolutionize ophthalmic education, particularly in resource-limited settings, and make training more efficient, scalable, and globally accessible. Thank you.
You have a video or something? How do you patients are practicing or something? Okay, no, you should have presented here only. You had still 1 minute of time left. So anyway, nice presentation. Thank you. I think we move on to the next
session.
मैं डाल देता हूँ सर एक